Dr. Badia here for another bi-weekly episode of our podcast, Fixing Healthcare from the Trenches. So today I'm very pleased to have a fellow hand surgeon, maybe I think the first orthopedic hand surgeon we've had on the show. And we have a lot in common in terms of private practice and I think our approach to care and in particular patient education, which we'll talk about particularly through social media. So Dr. Nick Pappas is joining us. He did his undergraduate work at Princeton. I'll try to overlook that, Nick. I'm a Cornell guy.
But I know, I've been to Ithaca many times, though.
It's a very dreary town, but you spend
it's very cold. I used to pitch there in the winter.
Right.
It was really
Nick
cold.
was a pitcher for Princeton. Yeah. Then went to a medical school at Vanderbilt. Went to University of Pennsylvania for orthopedics. A lot of great exposure to hand surgery. Then went back to Vanderbilt to do his fellowship, and he's currently on the adjunct faculty at both Tulane and LSU. And he started his own practice called NOLA, right? New Orleans
Hand Surgery,
NOLA Hand Surgery. Yeah. And you have some offices in Metairie and Slidell, but bottom line is you are potentially a dinosaur, Nick. Both of us are. So welcome to the show.
Thanks, I appreciate it. Yeah, hopefully not dying off like the dinosaurs though. I just started 2 years ago, so I'm hopeful to at least make it a few years. But I use your practice as an example of what I can become potentially. So I kind of like to see what you're doing sometimes. And I'm like, okay, this is where I need to go.
Well, this is the issue where we need more collaboration between us as colleagues. And one of the things in chapter 4 of my book, right, which is entitled Cats, Colleagues, and Collaboration.
Yeah.
We all know it's very difficult. Part of that, I think, are the challenges that we're all facing. But it's discussions like this that we need to have more of, whether it be in the hospital hallway or at a hand surgery meeting like we had in Toronto.
Yeah, I didn't get a chance to go. You know, I just started this kind of getting busier with my own practice, and I'm like, every time I spend a day away, I'm like, wait a second, like, can I afford to do this yet? Like,
that will change for the good. I hope. So tell us. I mean, what made you? And I can share a little bit about what happened with myself. But what made you go on your own at this point at a pretty early point, right? You're 10, 12 years into hand surgery practice.
Right. Yeah. I mean, I finished residency in 2011. So like 12 or 13 years in. I had been employed as an employee with a hospital system, even with the private practice group. I was essentially an employee. And during COVID, I think a lot of people realized this, that, your employer may not always have your best interest in mind. And, you reach a point where, I was tired of checking to see when I could take vacation or, always asking, okay, what's the plan for partnership or for this or owner? And you just reach a point where you're tired of kind of just answering to everybody else and having to, wait and see what they tell you your life is going to be. And I just was like, all right, I'm tired of this. I'm just going to take a chance and, I have a decent patient base. I'm just going to, make my own, start my own practice and see what happens. And that's what I decided to do.
Which is extremely uncommon, right? Because we are not able to share the overhead with others. Right. So it is but in terms of, professional satisfaction and tell us a little bit about patient satisfaction. I mean, what's that like?
When I was employed, they always are going to tell you, like, you need to see 40 or 50 patients a day or 60 patients a day. Right. We're going to space them out every 5 minutes or whatever time frame they're going to give you. And you're kind of told to kind of be in this mold, and you got to kind of push through the day. And sometimes, patients, sometimes visits don't just last 5 minutes. I mean, sometimes you need to spend a little longer for the post-op patient or, patients that have a lot of questions. And so I felt kind of like stuck in this little rut where I had to kind of listen to someone else telling me how to manage my patients. And I decided, to go on my own and have a little more independence. And I found that patients, a lot of times when they're in these big hospital systems that have doctors who are, RVU based, and they're trying to see a certain number of patients in a day, and they're told you have to see this many patients, they feel like a number, like they don't feel like there's individualized care. So most of the patients that come to see me, I mean, I tell people, you can look at my Google reviews, it's all the same. It's he spent a lot of time with me. We went over the x-rays, explained the surgery. I met the surgeon. I mean, a lot of times people say they never even meet the surgeon.
Yeah.
Like, how would you know if you feel like comfortable with them doing your surgery?
Right.
So that's the majority of my patient interactions. And I found that just, having in a given day, 20 or 30 good patient interactions, as opposed to seeing 60 patients where half of them felt like, wow, he seemed pretty rushed. I've had a much better response, and patients have been happier and I've been happier, basically taking more time for each patient and making sure they all have a good experience. And, that's part of what I'd like about having practice.
Let's not overlook that comment. You said that you're happier. I mean, I would think that a patient wanting, coming to see us would want their physician to be, not stressed, professionally gratified, right? Being on top of the literature and when you are not stressed with this sort of RVUs, which I
Right.
relative value units,
Yeah.
Patients don't understand that, but they do understand when you and your staff really treat them like they're the most important person at that moment, which they are.
Right. And I've been able to do things like one of my talking points was going to be about artificial intelligence and like computerized, systems. And some of the hospitals, I mean, you have to type a note basically while the patient is in the room, type it. And so you're not really paying attention. You're typing, you're focused on your computer. You have a scribe that's doing that. I don't really like that in my practice. I basically have eye contact with the patient pretty much at all times. Sometimes I'll have my medical assistant, type in things as we're talking, but like, that's one of the things that I've really kind of noticed that patients really respond to is they feel like even if it's for 15 minutes, you have given them your full attention and they don't feel like you're distracted, dictating, or doing something else. And that's what I like, the ability to at least say, okay, I want to have my practice be like this because I know patients like this. And in the long run, they're going to have a better experience. I'm going to connect better with them and the whole visit will be much better. Than it had been in the past where you're stuck behind a computer screen clicking, trying to get the charges in before. It just is too much.
This is granted. There's a lot of lay public is watching this because I think we're all concerned about healthcare costs. But I think for the physicians out there, even if they're not so young, it's reasonable to shift gears. I had kind of co-founded a hand surgery group. We grew to 5. It was a very strong group, all very good clinicians. But at one point, there were some changes, and I went off on my own. Mm-hmm. And so I've been 15 years now on my own, and now I'm about to bring on an associate. I'm very excited about.
Oh wow, a hand surgeon, another hand.
Yeah, another hand surgeon who actually had same training in terms of fellowship in Pittsburgh. Okay. So we have a lot of the same philosophy, but this is going to be a big change for him if he comes on board because he's used to that sort of, hospital-based practice. So I think I'm hoping that he really finds it to be a pleasant relief.
Yeah.
Yeah.
It is very different. It's funny in academics, you get taught a certain way, the way that academic doctors interact with their patients. I mean, it's somewhat similar to private in some ways, but I found that, as a private practice, you really have to connect with the patients. You can't kind of be this like, oh, I've written 50 papers. I'm famous. Like, come see me and get my, let me do your carpal tunnel. Like, you can't be like that. You need to like connect and you need to have patients feel like, look, you are giving them your full attention. You really, you care about them, which you do. But it's a very different environment than the academic setting. At least I've found to be successful in the private practice.
And the people like yourself, and I've been doing this for a few years. Is educate your patients, right? But not just in the office. We have a great tool now, which we should talk about. Mm-hmm. I mean, social media. Yes, there can be problems with it, etc. But it's an incredible tool to educate patients, and you've been amazing with that, Nick. So
yeah, I used it initially to help my practice get advertising. And then I started to realize, I used to have a resident at all times with me. So I was always teaching. And then when I have my own private practice, it's become a little more difficult to have a resident, from Tulane or LSU. So I just do the teaching to social media. And I learn stuff sometimes, especially about how the healthcare system works. That's why I like your social media because, stuff like pre-approvals, or I saw you posted about Medicare recently. I had a post about Medicare. They're proposed to drop another like 3.5% next year. And I'm like, look, this is what's happening. You got doctors like us that are speaking out. Doctors that work for a hospital may not even realize that Medicare is dropping their rates, and then wait till they check their salary 2 years from now. They're going to see that it's going to eventually hit them. So I feel like we're on the front lines, and I'm not beholden to any hospital. Like, I mean, if I say, this isn't going well, I don't have an administrator calling me the next day. Like, I'm on my own, you're on your own. And so we can kind of like be the sounding the alarm basically of, hey, this is happening. Other doctors, you better wake up because it's going to hit you in a year or two. And, it's going to decrease your job satisfaction. The fact that you're working more, making less, and your patients feel dissatisfied because you're having to spend, you're only given a certain amount of time. Basically, they want you to see 60 patients in a day, 5 minutes each patient, and, spend half the visit typing away so that you can get all the, details in before they leave, and they leave kind of feeling dissatisfied. It's like, so we're the ones that need to tell them, hey, this is time to act is now.
So we're on the front lines with that in terms of the economics and practice. But what I've noticed though, some of your posts are really, I like them because I really learned something, that you're presenting a certain viewpoint on a certain pathology. I mean, what's the feedback from your patients? Do a lot of them get to see that and learn?
I sometimes get patients just because they saw a video I did on hypermobility. It's not even something that's not even operative sometimes. Or, what's funny, you posted one of these too. I never actually saw a live distal biceps rupture. Until social media, people are filming their workouts now. So you're seeing these like patella tendon ruptures, like real time, or Achilles tendon ruptures. Like, when Aaron Rodgers tore his Achilles, people were all like, oh yeah, I usually see the calf bounce. Like, do you ever remember seeing a live Achilles rupture? I just knew it sounded like a gunshot and it hurt, but I never saw one live. So social media, and even how these fractures occur. Seeing how like a skateboarder falls and they hit their scaphoid first, or some of these knee injuries you'll see on gymnasts, whatever. It's actually kind of showed me, wow, these injuries are, it's like when you learn about fractures, the displacement is way more than you're going to see on that x-ray when it initially happens.
Right.
And so by seeing these happen, I'm like, oh, I'm learning as we go. Like, oh, that's why there's so much swelling.
It brings the interest to the patient because that part they can relate to. They can't always relate to what we're talking about, but now we tie it together. So I think it's a great tool. Obviously, when a celebrity, tomorrow I'm doing a live a Dupuytren fasciectomy. I do a classic Brunner incision. I've done a lot of different things. I've done McCash, but for a straightforward pretendinous cord. But the reality is the public doesn't know about Dupuytren's until John Elway.
Yeah, I like those commercials. Are you using Xiaflex much? I've had some friends not be as big of a fan lately, but I've used it in the past for like about 10 years.
Well, I think there are indications for everything. So I think it's important for us physicians to be facile. And occasionally you get a patient who insists upon something. And as long as it's not completely contraindicated, I try to comply with the patient's needs. Yeah. So no, patient education is huge. So bravo to you for that.
They like that. Like patients sometimes I think seeing that your doctor is friendly and educated and can talk draws them in to see me. I have patients that I didn't even know. Like, oh, I saw you popped up on my feed, and then I decided I want to come see you. It just seemed like you cared and you had a teaching interest, and I wanted to kind of just come see you for my carpal tunnel, something even unrelated to what I was posting about.
Oh, that's great. So what would you say? We're both kind of rebels in that area, right? But what would you say overall? What are three? I asked all the guests, right? Give me the top three very succinctly. Top three initiatives to lower healthcare costs.
Well, to lower costs, first of all, I think that to help the whole system, doctors should unite together, like us talking here.
Right.
I think employed doctors, I'm seeing it in the residents. They are unionizing, and I think that's going to carry over into like younger doctors are going to be unionized, and they need to tell hospitals like, look, this is what we can do to improve patient care and potentially lower costs. Like focus on things like preventive medicine. They just need to get their voices heard and not be afraid. Like I know Kaiser just had a strike recently. I'm not saying that doctors should strike, but like they should use some leverage to get their voices heard, because doctors, we should be the quarterbacks, like you say, of the healthcare system. We should be the ones pushing for things that we know are going to help our patients and potentially, lower cost. If we want to get a preventative test, like I can't even get a vitamin D level ordered or get a vitamin D level covered for like certain insurances. And that's stuff that's preventative. I mean, sometimes I think the doctors don't get enough of their opinion heard because we just kind of are just focused on seeing patients, and that can kind of drive up the cost. I think artificial intelligence, I know you've talked about this too. I foresee a world in my clinic, and I'm looking at it now, where I just have a phone that I leave out that picks up our conversation, that basically does the note, does the billing, even submits the bills, to whatever insurance companies. And I don't have to have 3 or 4 people in my office typing away all day trying to submit the right codes to Humana, the right codes to Cigna. Things get rejected, bounce back. So I see a world where artificial intelligence can take away all of that kind of bureaucracy, which is a lot of our healthcare dollars. I read somewhere it's 33% of our healthcare dollars. And I know you say it's 20% of our GDP. So that is a lot of money spent.
So collaboration, which we're doing here, right? The use of AI, right, to automate processes that we can say, so that we can do what we're really best at. So
and
number 3,
insurance company reform. You kind of mentioned, I don't want to steal your thunder, but like things like getting pre-authorizations for every surgery I do. At this point, I mean, sometimes the insurance companies don't even know what the procedure really is. How many people know what a 1-2 pedicle of Zeidenberg is for a scaphoid non-union? Yet, they're going to ask for my office note to review that to see if a vascularized graft is indicated. Like, who even knows that? I mean, that barely even other orthopedists maybe know that. So why are we spending our time? I mean, we did 10 years of training after high school after college to become a hand surgeon, 14 years total. And I still am getting permission slips for every time I want to do a carpal tunnel release. No one even knows, the details of that's in these insurance companies and what the true indications are. I mean, they could read a book, but I'd love to get away from that and then go from there.
I think that most physicians realize, that is biggest headache for us, but could be one of the biggest money saver. In fact, when I want to do a vascularized bone graft for scaphoid non-union, a Zeidenberg graft, I want to call Carlito Zeidenberg directly on his WhatsApp in Buenos Aires. I just saw him. At I forgot where, an internet.
I know the names. I'm younger, so I didn't realize they're still around. I know Orbe is still around.
His son is a hand surgeon now. But see, that's who we should be speaking to about whether a certain operation is indicated. I'll call Carlos and say, Carlos, do you think your graft is ideal for this? This mid-waist non-union with, it
just wastes our time, and it increases the cost because my medical staff will spend an hour dealing with like a denial. And the worst is sometimes you get approval and then they'll deny it. Have you had that happen where you get approval and then they deny it on the back end? You're like, wait a second.
Well, that's the Stephen King part of my book. Is
oh, really? Okay, yeah. I just don't understand the pre-approval then denial after the surgery. It's like here are my 3. I say oversight, not authorization or pre-approval. Oversight. So in other words, we're not infallible, right, Nick? Absolutely.
We should have people, looking and saying, hey, Dr. Pappas is scoping every single person with wrist pain who comes in, right? I mean, then you look into that. But you don't want to have a barrier or hurdle on every step of the way, because it's not just surgery. You need the authorization for this imaging study. You need it for then therapy afterwards.
Yeah, right? It just adds up. It's a lot.
So number 2 would be, and this is a big one. Number 2, because you were talking about the Zeidenberg graft, and I'm gonna let Carlos know that we brought him up. Right clinician at the right time. We have to get away from this concept that saving money is sending and making sure that our primary care colleagues have to see every patient before they get to us, the specialist. They don't have time for that. The primary care physician's job is to take care of our overall health, hopefully preventive, take care of chronic illness. They don't have time to see somebody with wrist pain.
Yeah. Also, there's a shortage of them.
Or expertise. So right clinician at the right time will save money. And the third one is what you've been fantastic at, is patient education. The more patients know, the better this will be for our healthcare system. It will ultimately save dollars. And
Yeah.
fortunately, social media is really a very inexpensive way of doing that. So bravo to you.
And it's a way to kind of cut through the media because, and you've seen this, I think sometimes things get shadow banned, like where your videos, are posted. And then like one of the videos you posted, we couldn't comment on, like your initial video. And it was weird. I've seen that happen on videos on other platforms where, it may be something like, it may be a sponsor that, doesn't like that message. And so that's another thing that, social media, like even though we can kind of get censored a little bit, it's still better than relying on the traditional media to report. Like I reported on how much pharmaceutical companies spend on spend on Congress every year to have their agenda heard, and it's $233 million a year. So I mean, it's not small.
Well, you're not going to hear that in popular media, unfortunately, because there's. I think the days of sort of investigative journalists, a lot of that's passed. So I really put out the challenge for somebody to say, what's going on here with healthcare? Let's take an interest. Hopefully the next debate, which will be right here in Miami, right down the street from me, I think it'll be at Univision. I can literally walk there from my practice near Miami International Airport. And hopefully that Republican debate, there will be discussion about healthcare.
Does DeSantis will be there?
He should be, yes.
Okay.
We will see. But stay tuned because hopefully maybe I can get DeSantis on here.
He's a Yale guy. We actually played baseball against each other. He was at Yale. He was a shortstop. I was a pitcher at Princeton. He's a couple years older than me, but he's a Yale guy. I know you're Cornell, so but he's a Well,
he was a JAG attorney, right, in the military. So I know one of it a gentleman who was running for governor of California, a very sharp guy, is friends with him. So at some point, we just need to get the politicians engaged. But I have had zero luck with that. But that doesn't mean I'm going to stop trying. I know you're going to keep trying.
I keep trying. I think I was telling my friends about this. I think it's almost going to take an event, like a black swan event where something happens, somebody's waiting to get pre-approval for, I know you were waiting for a fingertip amputation, but, it might be something, heart bypass, whatever it is. And, the patient doesn't do well as a result. And then they're going to backtrack and realize,
unfortunately, our society, it takes, whether it be John Elway, but it takes a celebrity and which is kind of sad. But I mean, I talk in my book about the Libby Zion case, which
I was about to bring that up.
Which caused us to have our work hours restricted. That's a whole nother topic.
Yeah.
But bottom line is, yes, there will be a sentinel event that will occur that will finally bring this to the public eye. But I thank you, Nick. I thank you for joining us and bringing this to light. And for all of you, please comment, share if you're interested in this discussion, particularly you colleagues. Please, let's collaborate. Let's get these discussions out in the open. So, don't just like us, just, share it with colleagues so that people can listen in, throw, tomatoes at us if they want, but at least let's engage.
Yeah, I agree.
Thanks for being with us, Dr. Nick Pappas. And I'll see all of you in 2 weeks, fixing healthcare